This is the third presentation about use of MDCT or the multi-detector CT, the multi-slice CT in chest and abdominal trauma, prepared by Prof. Sharaf and revised by Prof. Yusriya Sabri. It will be about urinary tract infection. You know that perihepatic and perisplenic fluid in trauma is usually due to blood, but perinephric fluid may represent either urine or blood. Therefore, when renal trauma is suspected, it is essential to obtain delayed CT images after contrast. Typically, 3 minutes delay is adequate. 3 minutes delay is adequate. CT findings in kidney trauma could be contusion, laceration, fracture, vascular injury, uretropelvic injury. Start with the perirenal fluid. This is the appearance of perirenal fluid enclosed within gyrotous fascia, and you know that gyrotous fascia is the fascia enclosing the kidney with its capsule and perinephric fat, and it is reaching down to the iliopsoas fascia. Laterally it is closed, superiorly it is closed, medially in children it is formed by loose connective tissue. That's why if a tumor occurs in the left suprarenal, the left kidney can shift to the other side or the reverse, but this is not valid in adult, where this loose connective tissue becomes fibrotic and organized, and so there is no shift of the kidney to the other side, even if there is a mass pushing it down or medially. So the fluid collects within gyrotous fascia, and the fluid, as we said, may be urine, may be blood, according to the type of injury. Renal contusion, it could be in the form of subcapsular hematoma or a small focal underperfusion. So it appears as area of decreased enhancement or area of focal underperfusion of the kidney. This is an example of a small subcapsular hematoma. It is a crescentic and biconvex. Now the word subcapsular, that means it is enclosed by the capsule itself and not by gyrota fascia, and the capsule is a structure which could not be stripped off the kidney. So the kidney and its capsule are considered one unit. So if blood collects under the capsule, subcapsular, it will be under pressure, under tension, and it forms a crescentic or biconvex shaped hematoma. Now here within the gyrota fascia, the kidney is lacerated and hemorrhage start to appear around the kidney, and you can see the limits of the fascia itself, and associated intraperitoneal fluid is also seen in this area. Now renal fracture, lacerations that connect medial and lateral surfaces through the hilum. These are the definition of the word renal fracture. It is the laceration that connects the medial and lateral surfaces of the kidney through the hilum. It's usually surrounded with renal hematoma, and as you see here, there are 3 examples of renal fractures: connecting, lacerations, shattering the kidney. Now vascular injury may involve both renal artery and renal vein, and in this case we can find complete underperfusion of the kidney, and the kidney is devascularized, and the kidney is replaced with a large hematoma surrounding. So devascularized kidney is seen in case of vascular pedicle injury, and expect that there will be hematoma instead or surrounding. Now, if the renal vein is thrombosed, renal vein thrombosis results in large underperfused kidney. Large underperfused kidney. This is the renal vein thrombosis. Now here there is active bleeding and retroperitoneal hematoma. Thus the left kidney is pushed forward, and the active bleeding is indicated by this contrast seen seeping around or leaking around within the hematoma. So this is a large retroperitoneal hematoma with the kidney displaced forward. Chelicell injury here is indicated by the presence of contrast outside the region, outside the confinement of the kidney, here and there. Thus you should expect that this collection would be mainly urine. It could be urine and blood, but there should be urine, because this contrast is seeping from the pelvis, injured pelvis. So chelicell and pelvic injuries result in collection of fluid, urine, and this after a while collects under the left kidney, inferior to the left kidney, pushing the kidney up, and thus and reaching down to the iliopsoas fascia and being enclosed within the garrota fascia. It will be a big collection called urinoma, pushing the kidney up and reaching down into the pelvis. So by time it becomes chronic and it becomes fluid which could be infected. So a urinoma is a collection of urine around the kidney within garrota fascia, and because garrota fascia is closed space, it reaches down to the iliopsoas fascia and pushes the kidney up, and the kidney even acquires a horizontal plane, horizontal axis. Pelvic chelicell injury and early urinoma formation. This is another case where the collection starts at the region of the pelvis, and with contrast, after delayed, we get the collection evident, extravasating outside the renal pelvis, and then starts to collect. This is how a urinoma is developing. Here we have pelvic chelicell injury, and the contrast is seen around the kidney again, and starts of urinoma formation. You cannot exclude the presence of hematoma. And here we can see subcapsular collection, and at the same time garrota fascia collection, and as well anterior pararenal collection. So you have the three possible collections around the kidney: anterior pararenal, within garrota fascia, and subcapsular, as well as intraperitoneal. Of course, if there is hydronephrosis, the kidney is more susceptible to trauma, more vulnerable trauma. This is a left hydronephrotic kidney, and contrast is seen around the region of the pelvis due to trauma. This is a collection, and the collection starts to increase down here to form a urinoma. Urinoma extension and relation to garrota fascia. It is enclosed with garrota fascia, which is closed medially, closed laterally, closed superiorly, and pushing the kidney up but reaching down to the iliopsoas fascia. How to differentiate between extraperitoneal rupture and intraperitoneal rupture of the bladder, because this has some impact on the management. Extraperitoneal rupture usually presents as flame-shaped contrast collection, flame-shaped contrast collection, or you might get the famous squeezed urinary bladder. Squeezed urinary bladder is usually due to pelvic collection, which does not give place for the urinary bladder to distend and thus becomes squeezed. And we call this the molar tooth sign. This is the molar tooth sign of collection around the urinary bladder, squeezing the bladder inside. This could be caused by masses, this could be caused by collections, and this could be caused by fat. So here there is a lot of fat due to pelvic lipomatosis, and here there is pelvic hematoma, and here there are two large pelvic masses. Usually lymph nodes can do this. This is the appearance of the molar tooth sign, denoting extraperitoneal rupture of the urinary bladder. And now you know the differential diagnosis: masses, hematoma, and fat. Masses, hematoma, and fat. Lastly, this is the intraperitoneal rupture appearance, and we know that the peritoneum is converging into the root of the mesentery, and thus any collection has a triangular shape pointing posteriorly. That is why, or laterally, that's why bladder rupture will give what we call the V sign. So intraperitoneal rupture, it has special appearance, it's called V sign. So V sign for intraperitoneal rupture, molar tooth for extraperitoneal rupture, and flame-shaped collection in extraperitoneal rupture. In emergencies, sometimes we will get deep venous thrombosis, so try to search for any changes in the femoral vein density. This is the normal density, and this is the deep vein thrombosis on the right side. Thank you.